In fact, how do you know level 2 and 3?
Guys don't know this. Now,
Actually, one of the issue was, if I live near Kenyatta, why would you force me to go to Motoinde? Example.
Yeah.
You get. So guys were asking, and I remember when we were looking at the SHA Act and all that, we asked, why can't those still level 4 and level 5 have some aspect of primary health care so that the people surrounding, because you need to go to the nearest facility to you, you get. So there are those people who live around a level 5, there are those who live around a level 4. Why would you force them to go all the way back to a level 2 and level 3?
what is happening now? Let me paint for you a picture of what's happening now. So what's happening now is patients are walking around with pieces of paper. That is the referral forms. Depending, so and I'm not saying referral form, you are making it look so nice. It's not a referral form. It's a piece of paper.
Piece of paper that is
yes. Yes, it's a piece of paper that
was
has been
taken
written
from
on
somewhere.
from a notebook. Because you
books,
see,
those two books.
Yeah, because you see,
any paper available.
I want to ask you whether you think level 2 and 3 facilities have been.
They don't even have printers.
Have been deliberate over the years to develop referral forms that capture all the biodata, receiving nurse, patients. No.
But the assumption was SHA had provided such forms.
This thing is supposed to be, and I still go back to 104 billion shillings is supposed to include a portal for referral.
An estimated 1.1 million Kenyans fall into poverty each year. And that's because of healthcare costs. Would SHA, SHIF, UHC change that, or is there more? Or perhaps, what's the difference between a pharmacy with a blue cross and a green cross? What about cancer and the rising incidence amongst the youth? Is it just lifestyle changes, or is there more?
Women's health, men's health, your children's health, the economy, this and more awaits you on season 2 of Kenya's favorite health podcast.
My name is Dr. Diana Wangari-Gitau, and welcome to season 2 of the One Health Lens podcast.
Hello, welcome back to the One Health Lens podcast. We're having an interesting conversation around the SHIF transition, and we're just going to jump right back in, right? And for context, in studio with us, we have
Dr. Simon Mushara Kigodu,
Dr. Brian Lishenga,
and Beatrice Cairo.
And I'm your host, Dr. Diana Wangari. It's been, 30 days. There's been challenges, right? We've covered a bit of that, but a big one has been around just fast patients, not just receiving care, but this referral system, right? Because Dr. Kigondo mentioned how his parents who have been going to this facility for the longest time went there a few days ago or a few weeks ago, and they were told, starting from now, you cannot come here because it's a level 4 facility. You have to start back and then be referred to us, right? So you can't show up at any facility. You have to be within a primary care network. From an implementation perspective, Lishanga, what is this network? Because I'm imagining it's different from, one, what used to be there at NHF. 2, it is also, I'm assuming, part of the contracting obligation. So what's this primary care network? How does it fit into the referral mechanism?
Okay, so the thought was that we would create around the country hub and spoke kind of arrangements where your level 4 healthcare facilities will be hubs and your level 2 and 3 facilities will be spokes, but there would also be a linkage to community because of the community strategy we have been implementing around community health promoters. So the community health promoters will be working, house to house or village to village and, helping us with the downstream determinants of health. And then they are linked to primary care networks. And the primary care networks design was initially around sub-counties or what you'd call constituencies. So the last time I checked, these were around 315 primary care networks, which are just about the number of constituencies we have in Kenya. Of course, they are slightly more than constituencies because some counties are much larger and therefore they used other administrative units. But essentially, they are sub-county based. Now, what also that meant is that they were intended to serve certain fixed populations, maybe 100,000 people per primary care network, etc. But you understand that our healthcare facilities are not evenly distributed. So some places, an entire primary care network could have a predominance of level 4 hospitals, in another places, level 2. So there are all those issues. The other issue was that a lot of those primary care networks had not been set up by, even as we are talking, because as at August there were about 160 or so primary care, half. So many counties still haven't set up all the primary care networks. And again, that statement I've made, counties. The primary care networks were being set up by counties, which meant your county executive committee member for health, your director for medical services, those are the people really behind that whole arrangement. Now, it created a problem because health sector is split almost evenly between public sector and private sector FBOs. So in most places, the CECs and the directors of medical services moved along. Where they moved along with their facilities and left behind private sector and FBOs to the detriment of service, which have to be part of the network. Now, so why they wanted to do this, I think the primary motivation, as I said, was the community strategy, but also the idea that primary care had not gotten enough attention. What you are describing, Kigondu's dad and mom walking straight to a level 4 and bypassing the level 2 and level 3. If we bring it to Nairobi, you would say people going to Kenyatta National Hospital instead of going to Mbagathi Hospital for minor ailments. Now, that's well and good. So where has the challenge been? The challenge has been that, one, primary care networks are not ready. Because as I've said, there was a structural problem where it was county government led and healthcare being devolved. The county government officers thought that this is a public sector thing. It is not the holistic health sector thing. That's the first problem. And then the second problem is that counties are different. So there are some counties where leadership has been good. And they moved along with setting up much faster. Places like Kisumu did a good job. Makueni have tried. I think Murang'a has set up almost all of them. So, and you'd find some other counties, the information actually didn't reach them. So they didn't even know that this was happening. But a bigger problem was that private sector and FBOs were wondering, and when are we going to be reached? When are we? Where are we playing? And in some places, they are the main providers of healthcare. Now, the second problem came to figuring out the reimbursement mechanism. How are you going to pay these people now that you have now said that I can't go to a level 4 straight, I must go to a level 2 and level 3 and get referred. Now, that reimbursement mechanism, there has been a proposal that has not been well received. Something called global budget or something like that, population-based reimbursement. And then, they went into technical issues that we are going to calculate the weight of diseases, the number of cases, and then it stopped being a capitation, because a capitation by definition is a prepayment, which is agnostic to the cases that will come. So you can no longer call it capitation. It is something else. It's almost like a fixed fee for service, because you are being told, I'm going to count how many cases of diabetes came to you, and then I will give diabetes a different weight from HOMA. So I will say it costs you more to treat a diabetes case than it costs me to treat a HOMA. And then I will calculate how many patients came per quarter times the weight times 900 shillings per year. It's not capitation. That is fixed fee based on a weight and a number. So providers became very cautious about this. They are saying, first of all, you've reduced this amount. Secondly, it is actually a fee for service. based on footfall. And now other providers came in and started saying, if you put me in a primary care network where I am the only guy with an X-ray and my X-ray is not directly reimbursable, people will send all cases to me. I will be busy with doing X-rays and I'm not getting reimbursed for it.
Yeah.
So now what? Where are we today? Here's where we are. Now,
Welcome, click.
it's just a thing is so convoluted and crazy because now where we are today is to their credit, finally they listened to us when we told them this is not gonna work. This just forget this. By 1st of October, not possible. And there was a subcommittee set up by PS Health, PS Medical Services, which recommended that the current, the former capitation mechanism continue as Ministry of Health and whoever figures out this structure. Now, in principle, we have agreed that it will continue. In practice, why is it not happening? There is no communication.
I mean, it sounds like, and it's the underpinnings of a lot of this transition. There was a very robust theoretical team, robust technical team, not theoretical.
It's correct. You're right.
Dangerous.
No, there was a very robust technical team. Economists, all those guys were there. Guys who no doubt have very
Expertise.
very robust expertise, right? Sounds like that was there. But then there was a disconnect between what's in theory and what's in practice.
Correct.
That it sounds like.
So there's a break. There's a massive break there because one, you would need a couple of years or months to just educate the public on why they have to start at level 2 and level 3. And because what you're talking about here is implementing behavior change.
In fact, how do you know level 2 and 3?
Guys don't know this. Now,
Actually, one of the issue was, if I live near Kenyatta, why would you force me to go to Motoinde? Example.
Yeah.
You get. So guys were asking, and I remember when we were looking at the SHAC and all that, we asked, why can't those still level 4 and level 5 have some aspect of primary health care so that the people surrounding, because you need to go to the nearest facility to you, you get. So there are those people who live around a level 5, there are those who live around a level 4. Why would you force them to go all the way back to a level 2 and level 3? Now, the other thing was, county, you know, the way that the referral system was, within the county, if it's public, there's a way they used to refer. So you come from a sub-county, you go to the county referral, right? And then when you look at the private sector, they also had their own unique referral system. So there is a way, if it's Nairobi women, they have negotiated with some clinics around that once you have such kind of cases, you can refer to us. I remember I did some of the quality assurance processes, and one of the things we were telling them to establish is a referral system. And to some extent, if Nairobi Hospital does not have some things, they can collaborate either with Aga Khan, or even go all the way to Kenyatta on, those kind of partnership. So one of the assumptions I think most of the county governments had done, when you tell them to set up primary health care, if it's for public, then the referral system should go in a straight line to the public, so they know how to coordinate with that. Now, remember, there is no exchange of information between public and private. I think there was a market survey that was done recently, and the report was out. And one of the issue was, there was that sharing of data between private hospital and public hospital is yet to be enhanced. So you see, private hospital can keep their data, public facilities can also keep their data. So when you introduce now a referral system, there must be an interlink, because if you're going to call me in the private sector a level 2, and then I have to refer to a county referral, there should be a means of exchange of information, because this patient, I'm referring from my private clinic to that county referral hospital.
But I thought this was sorted out in contracting, and I could be wrong, right? Because the last I had was, it will not matter whether you are going to public or private or faith-based. The contracts are going to solve these issues. There's the issue of the system, whether there is data, exchange and all this information exchange. But the contracts, did guys get the same contract? Did hospitals get the same contracts? What? be it public or private.
I'm gonna say that my assumption is they did, but I will put a caveat. No, they did as far as the packages which are similar are concerned. What I mean is that if I'm offering a maternity package as a private hospital, I think that that same package should be priced the same at public hospital. That's the information that we generally have. I should say here that the law recognizes electronic contracting. There are some physical contracts that were circulated, but they were a stopgap measure because the e-contracting portal was not ready by 1st of October, and they did not want to end up in a legal conundrum. So they quickly sent out, and I remember quite a number of hospitals complained. I know one hospital that has several clinics. They ended up spending close to upwards of 200,000 to just get print physical contracts, and then after they had done that, they were told to go back and sign the portal. Now, so to that extent, we don't know, because the contract in the e-portal, the electronic contract is not downloadable. So we don't know whether that's by design or it's just a technical issue, because most providers have been saying that I click, add, I provide all my details, and then I get a message at the end there that you have successfully signed the contract. But I don't have the contract, so...
What evidence would you have in future?
And the funny thing is that when you are entering your data initially, you're not reading the contract. You're just providing biodata.
You're just going, you're accepting.
You're accepting MFL code, administrator, email, etc. And then it's counter-checking with a database, the information that you're providing. And then at some point, it just says you have completed. And then there is a contract, but you cannot download it. I have heard that there is a concern that because of that, it is possible that people are getting different contracts. But transparency.
It's important. I mean, going back to what you said, we're already in crisis. There was already apprehension around payment. So I'm imagining even in claims, right? If they're going to arise issues around payments, then what do you fall back on?
You need to have a contract. I wanted to just speak up on what Cairo was saying about the HIE, the system of referral. You had asked me that question. And just to point that one of the things our surveys have shown is that plenty of level 2s and level 3s don't have digital infrastructure. They don't have computers. And it's not only computers, they don't have power backup systems. So if there's a blackout, they are blackout for real. And how are we going to implement a referral mechanism from level 2 to 3 to 4 if it's not digital? What is happening now? Let me paint for you a picture of what's happening now. So what's happening now is patients are walking around with pieces of paper. That is the referral forms. Depending,
So
and I'm not saying referral form, you are making it look so nice. It's not a referral form.
It's a
piece of paper.
Piece of paper that is
Yes, it's a piece of paper that
was
has been
taken
written
from
on
somewhere.
from a notebook. Because
Kasuku
you
books,
see,
those two books.
yeah, because you see,
Any paper available.
I want to ask you whether you think level 2 and 3 facilities have been
They don't even have printers.
have been deliberate over the years to develop referral forms that capture all the biodata, receiving nurse, patients. No.
But the assumption was SHA had provided such forms.
This thing is supposed to be, and I still go back to 104 billion shillings is supposed to include a portal for referral.
Okay.
So I think it does. Let me maybe take us back a bit to the interview we did with Ryan Nyotu. Ryan Nyotu is a specialist in the system. He has worked with the system for long. And probably, maybe for us to have an honest discussion, we need to stop branding, dynamic stories like 104 billion. Then you to make it look like it's the SHA system that is 104 billion. It is not. You see, it is actually the whole entire infrastructure of the health information system. And the referral is actually in the system. So ideally, every one is supposed to be logged into that system. So when you refer, it is in the system. I'll give you an example. I was this night in Kegumo Sub-County Hospital in Moranga. And as you know, we are, in Moranga County, we are totally digitized. And we had 2 patients to refer, critical, of course, eclampsia and, postpartum hemorrhage. And our referral place is Moranga County Hospital. So we write the notes inside the system and press refer. You see, and when they reach Moranga have access to it. So I think because we are here to live for long, and we hope to have such a system functioning in future, and because the problems we are having now is a change management problem, and I suppose, maybe not to use the word, almost vendor-driven push in terms of speed, then we do not throw away the baby with the bath water. So if I am just to put in context and just to put the 104 billion and not to stand in for government, the 104 billion ideally is for all infrastructure, including the computers, the network, the power supply, the system.
Okay, fair
and
enough.
and then if I am
Fair.
to
Fair.
what I am understanding.
Dr. Kigondo has just, and thank you for Moranga. It's one of shining stars, but he has just exactly added.
He's made your point.
My point very clear is that, you see, when you say the 104 billion includes everything, what I am trying to say is that it's not been deployed. Yes, it's not been deployed.
And it's also very...
And so we have level 2 and level 3 facilities that are not in Moranga. And what we are seeing in Moranga is an example of determined leadership that is local, doing it. But this is not the Kenyan reality. Yes. The Kenyan reality is that we have level 2 facilities that have never seen a computer, and they are telling us that, yes, I got my credentials on phone, but I have no computer to put them in. Now, let me even tell you something more interesting. Specialist services, eye services, ENT services, for instance, are supposed to start at primary care. Yes, for outpatient. For outpatient, they are starting at primary care at level 2.
Something new every day.
In fact, it will blow your mind when you read about eye services and ENT services. So I have an interesting interview I did last week with one of our ophthalmic centers, and they said, yes, they are receiving referrals because one, they cannot receive patients directly. This is a level 4. They can't receive patients directly, so they are receiving referrals. And so this ophthalmologist told me that life is so hard because the level 2 and 3 nurses and clinical officers have never handled ENT patients, have never handled eye patients. So what they are, so patients are basically going to a level 2 facility to get a note, a paper, which then they come to him with for care, and he is wondering whether this paper is admissible when the claim will be needed.
I mean,
it is not.
Are you getting what I'm saying? And therefore, it's. So the idea is that we don't talk about 104 billion because it's in public domain just for hype. It is, we are actually making a demand on those investors to deliver on their word.
Okay, fair enough.
To drop into that.
And final points.
The FIF bill, for example. Remember now, because we've introduced this primary care networks, level 2 and level 3. So the question is, the guys are asking is this. So will they also be involved in the budgeting process? Remember now, FIF was by where you retained resources or revenue generated by each facility, isn't it? No, if my memory can serve me correct, it was the health centers, all the way now 4, 5, 6. Now we are going now to that dispensary. We are going to that small clinic that was in that county. So now, will they also have the financial accounting management system? You see, this is what we are going to introduce, so that they, when they send a referral, they can also claim they actually saw that patient, and they can claim some money. And when that money comes on board, will they be subjected to the FIF? So that was one of the gaps also, some of these, because of sustainability aspect. So that, because will they only be making money for the bigger facilities, and then going down to them, they have to wait for the county to budget and give them money.
Fair. I mean, it's what's going to be our part 3 discussion, because
It's like we need a part 3.
we'll need a part 3, because I mean, there's a conversation around even facility improvement. There's a conversation around, it's not just SHA alone, right? There are other partners. This database of facilities is now being pulled from now Kenya Medical Practitioners Dentist Council. There are other partners involved, so that then we're not just spotlighting the Social Health Authority, yet as you can hear, implementation is counties as well, right? That's a conversation we're going to have in part 3, right? Thank you for now. We'll continue next time.